I've known Vincent for many, many years, and if he recalls, I think I do, as I examined his PhD thesis in Newcastle. So Vincent graduated from Newcastle initially, then became a clinical training fellow, CRUK, to do his DPhil. After his DPhil, he became clinical lecturer at Newcastle 2003 and became, I believe, the first CRUK clinician scientist that was given to a surgeon. Then he joined Cambridge, became honorary consultant, and has been leading a group now on prostate cancer research. He's got many publications to his credit, and he's got a number of very interesting projects that he has been leading, and his research is really very rounded, going from genetics through to having clinical applications of risk calculators that he will talk to us. And this is a powerful instrument, I believe, which has a lot of mileage. So he colleagues also the CRUK Cambridge Cancer Centre on neurological cancers, and a group on translational research and the clinical trials office. So without delaying you further, Vincent, warm welcome. Thank you very much for coming.
Thank you, Freddie. It's a great honor to be invited, because not only did you examine my PhD, you were also a senior lecturer at the time when I was a humble SHO and didn't dare speak to you. So I think I've achieved something to get here today. So thank you very much for the kind invite. And what I want to talk to you about today is actually a research journey as much as the things we've developed. Because when I started off in this area, I was led very much by what I was told needs to be done, and very quickly got to the point where I questioned what needed to be done, and now the question is, what should we be doing? So I'll first of all give you some context as to where I work and what I do. As Freddie said, I started off in Newcastle, and then got pulled into the Dragon's Den of Cambridge. And Herbie Newell, who was up in Newcastle, told me to be very careful when I went there, because it's full of people who are looking out to stab you in the back. It's not as bad as that, but actually it is a very challenging environment, and you really need to know your stuff, which actually is a good thing. These are the organizations that I, if you like, lead and have developed over the last 5 years. Obviously, we are lucky to have a big program of academic urology trainees and the academic urology group. We have set up the Cambridge Urology Translational and Clinical Trials Office, which is in these humble buildings up there, and we've got a fabulous team of people who work together. And I also happen to co-lead the CRUK-UM Urological Malignancies Program with Professor Eamon Maher, which is a very large CRUK-funded infrastructure for all kinds of research. More important than that is I'm very privileged to work together with some amazing colleagues. And one of the key insights that I can ever gain, have ever gained, and can ever impart is it is of no value to be personally successful because it only makes success for you, and your impact and your reach is very limited. Instead, we've been able to work with a whole bunch of colleagues here in academic oncology, clinical oncology, the basic sciences, engineering, radiology, pathology, and also our clinical colleagues as well, all centered around an infrastructure which has been very successful. We've had pretty good research income and many papers published. And this is the resource which I am very fortunate to work within to be able to deliver what we do. We also have this. Now, this is a bioethics called Diamond, which is actually one of the most powerful ethics around to be able to do studies, because we can flex it to do nearly everything. We have over 2,500 men in Diamond. We have got imaging, we've got guided biopsies. We can get them involved in ICM trials. We can get all their samples for all kinds of collections. And we've used it for a number of applications and also for redefining prognostic categories. At the moment, this continues to recruit for bespoke studies, but is a resource which is highly annotated to answer any question we have, and indeed allows us to actually undertake both multi-center trials and also translational research. We have led a number of national studies. These are just some of the ones we've just completed, working with many different sites, working around neoadjuvant studies, a new device for prostate biopsies we've developed, the Predict Prostate tool I'll talk about, and the PRIM-5 study, which I'll explain a little bit more about, which integrates biomarkers and imaging. And these connections has allowed us to explore how we take ideas generated from Cambridge and work with other centers. So to be clear, this is not studies that are coming from commercial companies or other bodies. These are things that we have actually originated. So I put this up to remind me of, if you like, where I started. So back in the day, when I was looking at my PhD, I was particularly interested in this molecule called CEF, because that was what the lab did in Newcastle. They were into molecular biology and FGF signaling, fibroblast growth factors. And I identified that this molecule seemed to be very important in FGF regulation and had a profound effect in altering biology. And this was relevant because growth factor signaling and FGFs was the area of interest in prostate cancer. And this led to a number of publications in lots of different journals, which was really nice for the science and actually advancing knowledge base. But it quickly became apparent to me that I wasn't actually sure where this was all heading. But it has been successful. This is a slide which I think Alistair might remember from Hunterian lecture some time ago. And we were able to show through many publications that the FGF signaling axis was altered at multiple different levels. Effectively, if you looked at one thing, that would not tell you the tale. So we showed that not only were ligands upregulated, the receptors were upregulated, and more importantly, there was a whole layer of regulation of these signaling pathways, which were also upregulated or downregulated. So in effect, if you were to design something to target this bit, these other things would compensate. And it actually turns out that this was a very important lesson in hindsight, because nothing sits on its own. And therefore, if you're only looking at one part of things and you forget something else, and you spend lots and lots of money developing a drug for that, you will probably fail, because the tumors can adapt, and in fact, people can adapt, funny enough. So really, at the end of all of this was this question of what was the relevance of the work that I, as a urologist, as a urological surgeon and interest in prostate cancer, was achieving by doing molecular biology at this level. Now, don't get me wrong, it was important work to be done, but the value added wasn't very clear to me. And then there was another piece of work which I did, because I was starting to think along these lines, as to what is it we were actually doing in the labs and what were we looking for, particularly around biomarkers. Because as a urologist, I was entirely focused on radical prostatectomies, surgical removal of the prostate gland, and that was what we were looking for biomarkers, relapse after that. So this was a piece of work which a PhD student of mine did, not published in a very strong journal, and all he did was he looked at the literature and said, well, what is the knowledge out there for how predictive biomarkers are across different treatments? Because we thought that we were doing fantastic work with biomarkers, but we were just looking at the surgical cohorts. And to cut a long story short, it turned out that Ki-67 was the only marker with global predictive value for survival. Ki-67, discovered in the 60s and 70s, and yet in 2013, still the only one which was predictive. So this is a bit of a revelation, because all of this stuff actually was all nice science, but it didn't actually contribute a huge amount. And that comes to the heart of the problem. In that, if you look at prostate cancer, it presents at all stages, it has all different types, and is managed by all different kinds of people. And actually, surgical involvement in the NPCA of 2018 was only 16% of all patients who were seen in the UK. Radiotherapy was 35%. So everybody else was getting all sorts of different things. So the research that was being done was very specific around this group of patients at the time. And even those doing radiotherapy research were around this group of people. And then, of course, you got people doing CRPC and all the rest, working around this group of people. And it quickly, again, became apparent that this was what was happening. That everybody had their own perspective of what was important in prostate cancer. It depended who you asked. The epidemiologist thought it was a slightly different issue. The oncologist saw one part of it. The scientists had a different aspect because they get into one particular area, which is what they have to do. And the urologist sees one part of that spectrum, except at the first diagnostic point. And this is a demographic, if you like, of prostate cancer. Your number of patients falls off as you go down the higher levels of treatment. 85% of all patients are seen up front in this point and will either go for primary therapy, with about 15% going on for ADT, and this number is falling. Most of the work that we were doing in the labs, new drugs, this, that, and the other, were coming around this area here, after relapse and salvage, and now more and more here. But up here, where we were seeing most of the patients, there was actually a pretty poor understanding of what was going on there. And effectively, how could you change that to make this not happen? And CRUK knew this as well, though of course they particularly like to fund advanced and novel stuff. On their website, if you go there, you will see these statistics, which look pretty stark. 11,000 deaths per year, 2016. 7% of all deaths, okay, doesn't look very dramatic. And then this startling number, which I find, even every time I look at it, amazing. The peak age of death from prostate cancer is 90. 90. So we have a situation where we have a lifetime risk of 13% and only about 4% of men were dying, which means that did we really understand who was dying of prostate cancer and how would you modify that? But also, we have this situation where most people diagnosed with prostate cancer are not actually going to come to harm from it. And this is not new. This is something we all knew. But how do you use this data? So this started a train of thought about actually what did we understand about risk? What did we understand about how you manage prostate cancer? The problem is that we are so conditioned to treat that we don't ask about the question of what happens if we don't treat. And this was a really nice paper which I'd encourage people to look at. This is from the PC-based dataset 2013, and it maps out what happens over a period of time, about 14 years, divided by age and these old-fashioned risk criteria, orange being risk of dying of prostate cancer, and green and blue is cardiovascular and other risk death. Now, it's a lot of data here, but you can immediately see that the orange stuff goes down here, which makes sense, it's metastatic. But you have to get to a pretty high level of disease before your prostate cancer mortality actually starts to exceed that of everything else. And not only that, you really have to be young at that point for this to happen. Otherwise, it's a bit of toss-up and you're more likely to die of something else. So this was data published, pretty much ignored because this doesn't fit a narrative. But this got me thinking that actually, as a urologist, as an academic, as somebody who wants to do something that makes a difference, how do you get it right first time? From the beginning to the point where you actually give a treatment. How much did we understand about that pathway? How joined up was it? And more importantly, how much did individual people know about this, who all see things from a different angle? So this is, in retrospect, but this is actually the journey in which we are taking at the moment. Now, early detection is a no-brainer. You can't move without hearing about early detection these days. So let's focus a little bit about this. So what is the work we've been doing around early diagnosis, precise disease characterization, to try to identify the population that needs investigation, to get your staging right, your assessment of how much disease there is, and making the diagnosis actually safer and more accurate. So I'll start off by saying that Cambridge has got a fantastic academic radiologist in Tristan Barrett, and we were very much at the forefront of the practical application and queries around MRI and the use of MRI for prostate biopsies. For those who are not in the prostate world, this is like the new holy grail. But we were able to show from a number of papers that MRI was actually a very useful tool to guide biopsies. And that is important because I'm not sure it can do anything else. And the problem with this is that the narrative around MRI has been very, very hyped up. These are the kind of headlines: the breakthrough in NHS trial, the prostate revolution, the one-stop service, all suggesting that you could use MRI to hasten the diagnosis of prostate cancer, and that was a really good thing. We actually knew for many, many years that even if you hasten the pathway of diagnosis from months to weeks, you do not alter survival from prostate cancer. It is not a cancer that benefits from a rapid diagnostic pathway. So what it will do is to reduce anxiety and stress. That's a good thing. How much are you willing to pay for that? The next bit is to understand what happens to all those people that you were missing before, because that was the whole cell. The cell was, with MRI, you would have picked up cancers you would have missed. And again, I would encourage you to read this really nice paper from the Danish group, where they looked at men who had a first negative prostate biopsy using the old-fashioned transrectal system. And they were able to, they demonstrated that in those men, the risk of dying of prostate cancer which was missed was between 0.7 to 3% over 20 years, versus an other-cause mortality of nearly 40%. So if you take a step back and ask, did we need a better test to pick up prostate cancer? You have to say the case is not very convincing. But most of this stuff comes comes post hoc, if you like, and it's a bit hard to unwind this. But this fits the narrative that not many people will die of prostate cancer despite you pick it up. And in fact, we were interested to know what MRI actually does pick up. This is the CPG system, which I'll explain a little bit more, but we looked at patients diagnosed in the cancer registry from 2001 and in our center in 2009 before we introduced MRI. And then after we introduced MRI, this is MRI and systematic biopsies, and this is just if you biopsy the target. And it doesn't take much to see that actually you don't actually see a preferential detection of more of these advanced high-grade cancers. In fact, a big drop came much well before MRI. And MRI is not perfect, as we were discussing last night. It can miss cancers, and also its indiscriminate use, which doesn't seem to be talked about, is going to cost a huge amount of money. Now, the case for MRI is very strongly being made. It's very hard to change the narrative. But these are the kind of things which make me think that, first of all, we need to ask basic questions before you go to advanced questions. And the EAU guidelines, actually, EAU panel actually suggested that you need something pre-MRI to determine who really needs an investigation. Now, of course, there are plenty of biomarkers out there, all promising to be really good, and there's 4K, which Oxford has published before, and we were interested in one called the PHI test, which has been around for quite some time. And back in 2016, we published this paper here, which effectively showed that in a repeat biopsy population, if you use the PHI of 35 to see who you needed to put through reinvestigation, you could actually pick out most of those men who had a significant cancer, and you would reduce about 42% of men having a biopsy. So this was obviously a big resource saving. But that is not enough, because then people talk about cost, this and the other. So we've just finished this study. Now here, what we did was, we didn't come up with a new biomarker because everyone's got a biomarker. We asked, how do you use that biomarker? Especially in an era where you now have a new paradigm of MRI and biopsy. So the PRIM study was designed to test this. How do you take a referral population and use the biomarker to refine and reduce the number of imaging and biopsies you do? So we recruited 500 patients, and the normal pathway was they would all go on to have an MRI and then a biopsy. And here we introduced a PHI test. So it was nothing more than asking people to have a PHI test, which is a blood test which you can do pretty quickly. And what we were able to see, and we are just writing this up, is that the PHI turned out to be the most powerful in predicting the presence of significant cancer. But of course, the problem is it doesn't tell you where the cancer is, so the MRI is actually quite important. But if you use that as a triage test, you could actually reduce the number of MRIs by nearly a quarter. You would reduce the number of biopsies by 40%. You would save about 20% of your costs, and you would not compromise on the significant cancer detection rate. So this is a very simple study in concept. It just basically said, where does this fit in the pathway? And really, unless you are able to do that, then all biomarkers you put are going to come across exactly the same problem that all biomarkers have always faced. They're great for picking up a test. No one knows how to use them. It's all going to cost a lot of money. Well, we'll think about it. And this is a piece of work we're doing with Andrew Fluid from engineering. He's developed a really neat system for film bulk acoustic resonators to pick up different proteins very rapidly. And we've done this with PSA, and the question is if we can do it with fine other markers for point of care. But this kind of infrastructure we have allows us to do this. So that was the first step. How do we improve detection? And there's lots of other work happening in that area. But the next step in the pathway was biopsies. Because this is something which is not very sexy. No one's really interested in it until MRI came and template biopsies. Of course, now it's very sexy. But the way we were doing biopsies is a problem because of the sepsis rate, because of the missed cancer rate. And of course, we have template biopsies, which are much better, but they cost a huge amount of money. And we were dealing with these infections by giving lots of antibiotics, and that leads to antibiotic resistance. And amazingly, we were getting about 2,500 men admitted with sepsis every year. Again, though, why is this such a difficult problem to solve? If you have this, which has sepsis, and you have this, which has no sepsis, why don't you switch from this to this? Well, it comes down to mechanics, costs, and access. So we developed a device called a CAM probe, which is a very, very simple and cheap device. The CAM probe is a simple coaxial needle system that allows you to do perineal prostate biopsies. We had an NIHR I4I grant to take it from a prototype surgical device, which was built in our hospital, to a disposable, and we've just finished the clinical trial for it to show its practical application. And the concept here was, how do you go to every hospital up and down the country and say, change the way you do biopsies, but here's an alternative which won't cost you more, which will actually pick up the cancers you want, is easy enough for you to do, and you can adopt it without having to buy lots and lots of expensive stuff. That was how we started. So this was a clinical investigation trial in 6 centers. We had about 40 patients to show the feasibility. In summary, no infections, much reduced antibiotic use, exactly the same cancer detection rate in this cohort. And now we're going to put it forward for CE marking. And like I said, it's going to cost about 10 quid. The next step is, now that you can do biopsies safely, you can start to think about doing biopsies as part of therapeutic assessments to see if things work. Because that was always a stumbling block. If you knew that the diagnostic procedure was a risky thing, you wouldn't do it. But if you have a way of doing it, then suddenly, safely, then you have a way of assessing your therapeutic effect. So these kind of simple things can actually make a huge, profound impact on how you do your research down the line. And the tolerance from patients is actually excellent in our study. So that was the diagnostic pathway, the MRI and all the rest, and in Cambridge we're fortunate to have some really, really, really good stuff going on there. The next question is, what happens when you detect a cancer? What do you then do with it? So here, we were particularly interested in accurate and personalized prognostics, balancing risk and competing mortality, which is particularly important in prostate cancer, and personalizing that information. And this again came from this kind of stuff. So when I was looking around to understand a bit more about where D'Amico came from and low, intermediate, and high, particularly because I had a failed attempt some years ago of trying to design a trial for high-risk cancer, I realized I didn't actually understand what high risk was. So I thought it must be in the literature. And these are all the different types of categorization systems that you can find by all these different organizations. The CAPRA score is one that gives a score rather than a category, and the nomogram here from MSK is also used quite a lot in America, not much here. And I was really interested to know, this seems to be a rather crude system, but it has stood the test of time. And we were then looking at our population data because I was also interested to understand how the disease was changing and how people were managing it. And these were 2 publications, again, not in very high impact journals, which showed some really interesting insights. Because in the east of England, it looked as though we were suddenly getting an epidemic of intermediate grade cancers. Because for some reason, all the grade 7 cancers were starting to go up and up and up, whereas all the rest were just going along what you'd expect on a route. And it turned out that the only reason this was happening is that pathologists were changing how they label things. Now, they were doing this, but for clinicians treating, when you go from a Gleason 6 to a Gleason 7, you're immediately going to treat, right? So this made me think, death rates aren't going up, survival isn't getting worse, so something is not right again. And again, this was because of a simple change which explained it. And now it turns out most of these grade 7s are actually not that aggressive. We were also seeing that management of low, intermediate, and high risk was also changing. And what was really interesting is that everyone was suddenly doing a lot more surveillance on low-risk cancer, which is right, and high-risk cancer was also changing a little bit. But here, everyone had their own thing going. Everything was up, everything was down, no one really knew what to do. And this was how we were managing prostate cancer. So I said, okay, if that's the case, well, how good is this nice criteria, the low, intermediate, and high, in predicting cancer mortality? So we published 2 papers on this. The first was in 10,000 men in the UK. And we found that the concordance index, the ability to predict mortality using the NICE criteria, was actually only 0.67 to 0.69, which is not very powerful. And yet that is the recommended guideline in this space. So what we did was, I said, well, can we make this better, because I have no money, by simply looking at the data. And we rejigged it and did combinations of factors and produced the Cambridge prognostic groups. And what you immediately see is 5 strata all performing very differently in terms of mortality. And what was really striking is that you can't subdivide low risk anymore, but if you split this intermediate risk group into 2, you find 2 very different performing groups. And this group up here has, if you can see that, a 95% 10-year survival, whereas this one starts to behave more like high-risk disease. Even more interestingly, if you took the high-risk category and split it out, it turns out that there is a better performing high-risk group and one which really does very badly. And I will tell you the subtext to this is that how we are selecting the treatments for individuals starts to split the minute you start to split this. And this had a predictive index of 0.76 to 0.83. So by simply looking at what we already knew and rejigging it, we were able to improve on the predictive power and selection of patients. And so we produced the Cambridge Prognostic Groups Calculator, which is a website you can access and use, and it's a very simple system because it was designed to be simple exactly for the reasons I said. You need to try and produce things that people can use, not complex stuff which they don't understand or is difficult to use. And just this year, recently, I was very gratified to see that this paper came out from a Swedish group where they compared all the known guideline systems out there, including CAPRA and MSK, and I didn't know they put the CPG in, but CPG came out as in the top 3 performers and actually outperformed all the other risk calculators. And I didn't even know this was coming out. Obviously, I was very pleased when it came out. So this system, if you apply it already, is more powerful than any other risk stratification system, and I would encourage you to have a look at that. But I will tell you later that research is an evolution, and that is exactly right. But the title of my talk is how do you use this kind of stuff to change practice? Because the things that really affect practice for clinicians is not the science, it's the practical application of it. And this is an example of how we've used it. This paper was published in the BJC, and we asked a simple question: can you select the patients who need and don't need bone scans? And we tested this and found that if you were in CPG 2 or 1, you never had a positive bone scan. It's only when you move to these groups that the risk becomes higher. And so we applied this, and we were able to reduce our overall use of bone scans by 25%. And this is now hospital practice. In addition, we are able to identify this very poor performing group, like I mentioned, and this is the group we're now targeting for research, for example, in neoadjuvant trials, and also by using this to identify those who benefit from PSMA scans and the use of circulating tumor markers to identify predictors of outcome. More importantly, this is now feeding back into the research because we want to find those high-risk men in the population, the very high-risk men. And working with Charlie Massey, with his technology around ctDNA, we've been able to categorize patients in our biorepository by these systems, and actually we're looking now for those markers of the really high predictive disease in CPG5 and METs and comparing it to the low and cancer-free groups. So the minute you're able to better stratify your patients, this starts now to identify ways to use that to pick out and develop the tests you really need. And this is another example of how we're using that data. Now, in prostate cancer, if you're not going to treat, then you survey. But surveillance is done ad hoc by everybody, anywhere, in any fashion you like. Surgery is centralized, radiotherapy has standards, surveillance has no standards. Because nobody knows what's safe to survey, nobody knows when it's unsafe to carry on, and nobody knows when to stop. So what we did was very simply, we said, what if you applied the CPG criteria and you worked out what happens if you treat and don't treat? So that's what we did with this large population from Sweden. And in a nutshell, you can see this is the CPG1 very low risk. This is CPG2 of men treated conservatively or with treatment. And this is the group of CPG3, which is treated conservatively or with treatment. And it's only this group that you actually start to reduce mortality when you intervene. It means that these groups here are generally going to be safe on surveillance unless they reach this point. And once you have an endpoint, which is CPG3, you can start to actually build the models to predict that endpoint. And that's what we did in this paper, and we identified a couple of these endpoints which are able to predict that. How do you use it in clinic? Well, if you have a combination of those factors, that predicts how you do. If you are in CPG1, which is the lowest risk, and you have a low PSA density, your risk of progression to CPG3 at 3 years is actually only 1%. Whereas, if you have CPG2 and a high PSA density, your risk of progression is nearly 20%. And how you can use that is you can start to tailor your follow-up based on risk. And this is StratCan's program we've just started in Cambridge, where we put people into a low, moderate, or high-intensity follow-up regime, and we design how we do their surveillance accordingly. But that's all very well, but what we were doing was still putting people in baskets. Admittedly, it was 5 baskets rather than 3 baskets, but it's still baskets. And people are not baskets. They don't like to be thought of as baskets. So this is the next step. Once you have the first idea, the second idea follows. How do you personalize this? how do you estimate for an individual their own risk of cancer mortality versus survival mortality from other things, and then contextualize the benefit of a treatment? It so happened that we were fortunate in Cambridge to have Paul Farrow, who had developed a tool in breast looking at treatment selections after surgery. And we discussed how you might develop this for prostate, and developed Prostate Predict. And Prostate Predict takes data, which we all have already. We have the age, the PSA, the clinical stage, the comorbidity. We've got BRCA in there as well, metastatic or not, so the tool is only for non-metastatic men, the grade, the amount of biopsy involvement at diagnosis. And it gives outputs of 10 and 15 years with and without treatment on the estimated benefit of treatment over non-treatment, and also the risk of dying of something else. And the tool also has, though not personalized, side effects data from large cohort and RCT, including from the PROTECT trial as well. And what this allows us to do then is to have a discussion with patients about what the value of treatment is. Because when they can see the numbers like this, and if you use the website, you'll see there's different displays you can put in, it starts to actually give you a very accurate idea of whether or not that treatment is going to help someone or not, to make that decision. And it turns out that everyone you ask, clinicians-wise, would have a different view of that. And so the patient was subject to who they saw and what that clinician's thoughts were. And the way we were able to demonstrate that is by this study. So before we published the website, we sent this out to about 200 clinicians, and we asked them what they thought would be the mortality outcome from prostate cancers of different types, and also their likelihood of recommending treatment. And then they were either seen with the tool and without the tool. Now in this image here, the green is the estimate of the Predict Prostate for actual cancer mortality. Of the clinician's estimates of cancer mortality, whereas the blue was what Predict estimated was the cancer mortality rate. And you can immediately see, I think, that in nearly all circumstances, the clinicians overestimated the prostate cancer mortality rate compared to the Predict model. And as a consequence, most of them were recommending treatment. And when you gave them the Predict tool as well, you saw a massive reduction in the variance of decision making, and actually by 30%, and the number of recommendations for treatment fell by nearly 60%. And this was by no more than putting the same data and putting it into a single tool. Now this, we think, is a much greater effect than actually treatment survival outcomes by different modalities, whatever you may choose, because we were not asking them to choose between surgery, radiotherapy, or whatever. Simply, should you treat or not treat? If you have such a massive variation in just how clinicians are counseling, then how can you hope to show a benefit from one treatment or another? So a tool like Predict is designed to, first of all, capture that and standardize the baseline information. And we've been very fortunate that we've had good uptake of this. It's been endorsed by NICE. We've had about 23,000 sessions since we launched in March of this year, and we was awarded a Vice Chancellor's Research Impact Award from the University of Cambridge just a few weeks ago. It's also been adopted by the East of England Cancer Alliance along with our CPG tool, and the real challenge now is to try to get these people to use it and to try to give their patients, because the tool is patient-facing, access to it. And in fact, we've just launched a video on YouTube for patients as well. We're currently running a patient study to assess the impact for patients in using this. It's a multi-center RCT in 10 sites. And we're going to see whether or not it helps with their decisional confidence, their decision-making with regards to treatment, and actually patients' perceptions, their own perceptions about how risky their cancer is. There was an interesting discussion last night about decision aids. And in prostate cancer, most decision aids are basically asking you, which treatment would you like? They're not asking the question, do you really need to be treated? And how can you make an informed decision if you actually don't even know what your risk is? It's ridiculous. You wouldn't buy something from a shop if you didn't know whether you really needed it or not. Well, I suppose some people might. Anyway, so you can see here that this is a process. So the next process is, how do you use this kind of stuff to individualize treatment and improve outcomes? And one of the things that I'm really passionate about is not having esoteric stuff. So you can personalize therapy, but how do you get it into man? And also, how do you combine the research and state-of-the-art treatment? One of the biggest barriers we have as academics, it's a no-brainer to combine your research with what you do. But for clinicians, it's very hard to do because you are bound by targets, by things which are not to do with patient benefit. So you need to be able to work with systems to allow this to happen. So I remind you again of this graph here, and I remind you of this population, because to my mind, these guys are actually doing pretty well. I mean, this level here is 80% 10-year survival. I mean, you're really hard-pressed to improve that, actually. Whereas these guys, we are still giving standard radical treatment. This is not metastatic men, to remind you, and we are getting dismal survival rates. So with Simon Pacey and Ann Warren, we have already been working on neoadjuvant surgical trials, and we've done 2 of these already, where we're trying to give drug to see effect, and this is a kind of design and model which is very interesting. But where we're really interested in is actually personalized medicine approaches in primary prostate cancer by integrating all of these tools that you see above. Because it's not enough to do one thing. Like I showed you that picture of the elephant. Each person has a different view, but how do you put it all together? So this is an illustration of how this might work. This was presented in the Grand Ward Round earlier this year in Cambridge, and how we can use these tools. So I'll give you an example. This is a 61-year-old chap with few comorbidities. His PSA is 6. His MRI shows organ-confined disease, and he's got low-grade disease in just 1 sample. You put his numbers into PREDICT, and these are the only fancy pictures I have, which is Tristan's MRI, and it shows you the lesion, which is going to be sitting somewhere there. Or not, actually just goes to show. But in summary, what happens with this guy is that he has a very low risk of any harm coming from his prostate cancer. So at the moment, he has all these various options, and we are unlikely to treat him. So in this kind of guy, there's really not much point throwing things like genomics and personalized prognostics and all sorts of fancy gadgetry in here, because he's actually not going to come to much harm. But let's take a different context. Let's take this guy who's 71 with a PSA of 53. He's got locally advanced disease, and he's got high volume disease. At the moment, his bone scans and CTs are negative. Now, if you put his numbers into the PREDICT tool, and you go through a process of looking at his histology, this is typical high-grade disease, and this again is his MRI, and these are his bone scans and things, all fairly standard stuff. But when you put him into PREDICT, this is what the tool calculates, that for this particular guy, despite having radical therapy, at 10 years, there will be about 31 plus 18, about 40 to 50 who will still be alive, but half that cohort will actually already be dead. And of those men who are dead, more than half of those deaths are going to come from prostate cancer. And giving radical treatment to this chap will actually save only 18 extra lives. Now, beforehand, you wouldn't know these numbers. But when you look at this and you realize that this guy with standard therapy is still going to have a very high risk of cancer death and the process that goes with that, then the question is, what are we doing to improve that? And this is where the personalized medicine program comes in. So because we can do image-guided biopsies, because we have the MRI, because we have the PSA, we can already identify with a high degree of accuracy who are the guys who are likely to harbor aggressive disease before they even land for your biopsy. Because we have image-guided biopsies and ways to biopsy which are safe, and MRI-guided biopsies, we can take samples from those tumors with high degrees of accuracy. None of this is out of the realms of standard of care. And what we've done is we've taken that information from the imaging and the guided biopsies, which we do anyway. We've taken that stuff, we've taken additional course for genomic profiling. We've taken samples, for blood samples through the Diamond system for ctDNA and profiling, and we're putting it through a cancer molecular diagnostics panel. We then give that clinical data and put it into PREDICT, and we discuss it in a molecular MDT. And this molecular MDT, we've been able to show can be achieved with a 30-day turnaround. So nothing out of the ordinary, part of clinical care, but we are now able to integrate all this information into one. And the question really is, what do we do with it? This is an image of one of our virtual MDTs. We've done about 16 to date, and we've got about another 3 waiting to be discussed. In this particular individual, we were able to identify PALB2 and RAD51 mutations in the somatic gene sets, as well as HRAS, FOXA1, and SPOP mutations. What is striking is that when we looked at the whole population of 16 patients, we actually found DDR gene mutations in more than half of the population at primary tumors, not treated populations. We also found cell cycling and survival mutations in quite a few number, and PTEN and Notch pathway alterations. Now, this is much higher than what people have normally seen with primary tumors. And if you look at what's been published before, the question is, why is it so much higher? And it's again because of not knowing which populations you really needed to do this stuff on. So if you look at this data here, this is from the TCGA dataset from the States, and this is from a paper from Nature. And you looked at the cohorts from which they actually took these samples and did the profiling. It turns out that only about 1 in 3 had high-grade disease, only 1 in 3 had locally advanced disease, and so most of them were actually not particularly lethal tumors. Again, similarly, if you look at this here, only 1 in 3 had high-grade tumors. They found about 25% and 19% DNA repair gene mutations which could be activated, and that is similar to nearly every study published there. But in our population, we are starting to see that actually there's quite a lot of mutational burden which can be acted on with drugs. And we're now currently discussing with drug companies to see how we can bring this thing together and use this kind of data to actually alter survival rates in the patients who absolutely need it. So where we've got to where we are has been an evolution, and this is pretty much where we were when I started in Cambridge. And this was an aspirational slide as to where we would get to. And actually, we've actually pretty much ticked all the boxes here. We have the infrastructure to deliver on image guidance, on genomic profiling and personalized prognostics, and we're now starting to explore this, and the next step is to actually do precision-tailored treatment. But the pathway to changing research, to changing practice with research is actually very difficult, because you have lots and lots of ways of showing things are impactful, but how do you get that change out? And actually, I found this to be one of the biggest challenges, that no matter what I can actually show, even to my own colleagues, I can't get them to engage and use it. No matter how easy I make it, it doesn't seem to register. So I guess that's a slow-growing process. But what we've tried to do is to do all this research very much at the cold face, so that it's in their face, if you like. They see it. When they do their biopsies, we say, can you take an additional sample? When we sit in the MDT, we say, look, let's use the predict tool. And all these things show that you can bring this into practice. And most clinicians find it very strange that I'm suggesting this. But that's the only way, I think, that we can actually make change and therefore help the research evolve. Because otherwise, most research tends to stop at the point of a high-impact paper or a trial and then doesn't translate into practice. Few make impacts like Protect and others, but others tend to not to. So, strangely enough, I find myself in a position where I actually have people who are now developing outreach and public engagement. And this is an example of this, a course we ran a little while ago in Cambridge, where we invited people to attend a course on how to use some of these tools, and we had about 22 people from 8 centers. And we had excellent feedback, and this is some small graphs showing how similar cases like you saw before actually changed in terms of what the attendees would do once they saw these tools in action. And I think this is the way that we have to do it. We also have to, in some way, be publicists for the work we do if we truly believe in it. And in the same way with the Campro prostate biopsy device, and workshops and teaching people how to use it and disseminating it, and actually using social media to actually bring all these things out. So nearly everything we do is posted there so people can see it. It also becomes a very easy reference point when you're talking to people and you want to explain complex things quickly. So I'll finish there and tell you what I've learned. And that is that you have to do what you can with what you have. Most of what you've seen was not funded by large grants and lots of money. It was actually done with nothing more than an idea, goodwill, and actually a little bit of this and a little bit of that. Research is an evolution, it's not a goal, meaning to say that you're not going to discover something and that's the end of it. In fact, if that's what happens, then actually it wasn't worth doing. Everything you do has to evolve to the next step. And the other thing which I've realized is that for me to make an impact at least, I have to be a disease specialist, not a discipline specialist. Because if I was a discipline specialist, then I would have followed a particular route and that's all I would have done. When you are a disease specialist and you can see a disease, whatever that is, from all its angles, then you can really start to make impact because you can convince other people that you're not just looking at it because you're particularly interested in one aspect. And you really have to do what interests you and not necessarily what gets into a high-impact journal, because none of the work you've seen is in particularly high-impact journals, but it has got high-impact value for patient and clinical benefit. And that is a strange dichotomy, which I find unusual, but other people may be able to comment on that. And oftentimes you have to believe in yourself and your ideas, because a lot of people will tell you it's not interesting. If you're a clinician, you must align your research and your clinical work together, because if you don't, then while you're funded in a lab to do stuff, it's great. But the minute you're not, it's very hard to sustain that interest when you have other impacts. And challenging perceived wisdom, even your own, is the most important thing to do. Because sometimes the thing you assumed was right may not be right. And sometimes your seniors may not be right, because don't forget, they also came through that process. And very often, what they thought they got to was the bee's knees. But research is an evolution. So I'll leave it there, Freddie, and I'll thank you once again for your great hospitality and for inviting me today.